Now it gives me a great deal of pleasure to introduce our next presenter speaker, Professor Estefania Oliveros from the USA, who will give us her presentation. She's from Temple University in Philadelphia, Pennsylvania, and she will give us her presentation entitled Under Pressure, Hemodynamics, Bringing the Right Fix to Heart Failure. Very exciting and thrilling title. We look forward to your presentation.
Thank you so much for inviting me to speak today. I am very excited to share with you this exciting and kind of like different case. And it shifted somehow how we think about heart failure. And I hope it brings some like great teaching points to the audience. So as an introduction, we have cases of high output cardiac failure that develop in the cases of elevated cardiac index, and this can lead to severe pulmonary hypertension and can be very challenging to manage. There are limited advanced heart failure management strategies for this group, and it's very hard at times to be able to reverse pathology. So I bring today a case of a 65-year-old male with worsening hypoxic respiratory failure. His past medical history was significant for CAD, status multiple PCIs. He at least had 10 procedures done to his coronary artery disease in multiple stages, 2011, 2013, and the latest was in 2018. He had a history of heart failure with ejection fraction of 40% and severe right-sided heart failure. He was a 60-pack year smoker and had paroxysmal atrial fibrillation. An initial part of his relevant history was that 1 year prior, he presented to a hospital where he required impella-assisted percutaneous intervention, PCI, where he had a proximal LED stent that was placed. After that, in the ensuing months, the patient started having a severe bilateral lower extremity edema. It was almost like lymphedema when he presented to us, to the hospital. He had abdominal distension, severe dyspnea. He could barely walk across the room, and he was just gasping for air, orthopnea. The reason why he decided to come in was because he was refractory to therapy in the outpatient setting, despite high dose of diuretics. The medications included apixaban. He only tolerated furosemide 80 milligrams daily. He kind of self-titrated this medication. Metabolism 5 milligrams BOQ daily. He was on aspirin 81, Plavix 75, and carvedilol 3125, Q12. On his physical exam at arrival, his blood pressure was 97/66, a heart rate of 109. He was afebrile and a respiratory rate of 19 respirations per minute. He was setting 93% on 2 liters of O2, and that was at rest. With mild just movement in the bed, he would desat down to 80%. Jugular venous pressures were elevated up to 20 with very large V waves. This was someone that you actually had to sit up to actually be able to see the top of the jugular venous pressure. He had also an irregular rhythm with a very loud second heart, an audible third sound. Parasternal heave was very prominent in him, and he had a left lower sternal border murmur. He had bilateral crackles and a very prolonged respiratory phase with a chest that was also consistent with someone with findings of emphysema because of the diameter of his AP. His abdomen was distended, and he had very pulsatile liver, which is consistent with the higher jugular venous pressure that you see above mentioned. And one of the interesting findings was that he had a very noticeable audible bruit, with positive 3 in the right groin. In his ancillary studies, he had a sodium of 123, consistent with severe and chronic hypervolemia and heart failure state. His creatinine was 1.25, which was above like his baseline of like 0.8. Bilirubin of 2.2. He had elevated LFTs, as you can see in the slide, and a mild troponin elevation of 0.09. His initial BNP at admission was 1528, which is abnormal above 100. He had sinus tachycardia, right bundle branch block. EKG had also right atrial enlargement and Q waves in all the anterior leads. His CT was done, and it was negative for acute or chronic PE. And we were able to find an AV malformation, AV fistula in the right femoral vein. This is the initial TT, an EF of 40-45%. And as you can see in these images, and I'm sorry that I'm not sharing the rest of the echocardiogram, he had a very dilated RV, severe TR, bicolor Doppler. He had RVOT notching in the RVOT inflow, suggestive of elevated PVR, and very low flows through the VTI, RVOT VTI. We proceeded also to do cardiac magnetic resonance, and as you can see on the slide to the left, you can appreciate how there's significant amount of dysynchrony in the septum, which is consistent with that overcoming RV failure that's in conjunction with the pulmonary hypertension. You can also see on the image on the right a very dilated RV, and you can also appreciate the severe tricuspid regurgitation. When we did late gadolinium enhancement, there was also evidence of scar consistent in the territories where this person had coronary artery disease. I apologize about the images from the left cap. There was patient identification information, so it didn't allow me to show you the whole film. But this is the RCA, which he had that known occlusion that you can see here, almost like a 90%. It was deemed very difficult to access because of how small the vessels were. And that's why in the past he had required like impella support and the things that I have mentioned. The LAD, you can see here how the proximal stent is still open with some distal perfusion, but it's a very diseased coronary arteries. So in the interim, we were able to obtain some of the images, and we were thinking, why are we having so much worsening of the RV failure? The patient in reality has some component of coronary artery disease, which is there, but it doesn't seem to be able to explain. The coronary angiogram was repeated. The coronary angiogram images that I showed you were from 3 months prior, and it was exactly the same in this acute presentation. So the plan after the patient was diuresed, optimized, but with cardiac indexes that were very low, were to actually think of heart transplantation. He was deemed inappropriate for an LVAD at that point, given the severity of the RV failure. And that's where we started trying to put everything together. Sorry, I apologize. This is, oh no, I gave it away. This is a representation of how like the AV fistula was looking in his right groin. We actually proceeded to do a right heart cath, and where we were able to find an RA initially of 5, RV of 50/16, a PA pressure of 15/24 with a mean of 34, and his wedge was 11. His cardiac index at that point was 2.8 and 5.4. And we were able to find that AV fistula. What we did during the procedure was we actually occluded the fistula And the cardiac index and cardiac output went to half of what you see on the slide, and there was significant drop in that, and we were able to prove that that AV fistula was actually providing a lot of that extra flow. Then the procedure that was decided, instead of undergoing all these very scary pathway of heart transplantation and whatnot, was to actually close the fistula. And these are the hemodynamics that you see on the right. And this is actually the results of his RV, which is basically normalized. And here is the echo 1 month after. This patient was discharged off milrinone, on still some Coreg and aspirin and Plavix. So basically, this is a case of AV fistula that can lead to high cardiac output state and RV enlargement and failure. Concomitant left-sided heart failure and lung disease were thought to be contributed to the severe RV failure and pulmonary hypertension. And given his rapid decline and end-stage cardiomyopathy, he concurrently was undergoing all these advanced heart failure therapies, but simple correction and good physical exam of the AV fistula made a dramatic impact in the improvement of hemodynamics and functional status on this patient. Thank you very much.
Thank you. This is a wonderful case, and I think we can summarize it in a very short sentence. Radial PCI. Because if this patient had a radial PCI, he would not have had the femoral complication, and which is probably the reason for it.
Definitely, yeah. So these patients had so many procedures, and I think one of the issues was when they put the Impella for the complex PCI 2 years prior of his presentation, like that's how when the iatrogenic fistula was there. And what's interesting is that he had been seen by multiple cardiologists and transplant centers across for about 2 years, and he was on and off milrinone, and it was just as simple as fixing the fistula.
Yes, please. I thought the symptoms were continuously deteriorating, getting worse after the last PCI. Is that correct, or did I misunderstand?
No, the last PCI that required Impella.
Okay.
2 years prior, yep. Mm-hmm.
Okay.
Can I ask a question, please?
Mm-hmm.
Can I ask a question? Yeah.
Yes, please.
Dr. Oliveros, this is amazing. Thank you very much. It was very, very educational. Your slides on the right heart cath and the occlusion are beautiful. My question is about the hyponatremia. The sodium was 123, and you said that that was consistent with his state of chronic hypervolemia, right? Did I hear right?
That's correct, yeah.
Yeah, because I see this a lot, and I see a lot of panic and people trying to correct the hyponatremia in patients, in fragile patients like this, by sodium chloride infusions and stuff. So if you can just elaborate a little bit more on this. I mean, what was his hematocrit? I mean, was he hemodiluted or?
So yeah, that's a fantastic question. Thank you so much, Hagi. This is something that we really see in our heart failure patients when they have severe hyponatremia. And it's also related to this hypervolemic state and dilation of our the atriums, right? And how all it comes down to elevation of ANP, BNP, and the vasopressin in the system, and how you're trying to dilute because your system is thinking that you don't have enough volume. That's what you're perceiving, right? His serum osmolality was very low. He was diluted. Even in the the pH and like the density in the urine was diluted as well, which was very interesting. And as we just started diuresing and decreasing the pressures in the right atrium and left atrium, you could see an improvement on the patient, and he ended up being discharged with a normal sodium of like 135.
Thank you.
I noticed something else that I found was very interesting. In the pressures, the cardiac pressures, the RA pressure was only 5, which I thought was quite low. I expected it to be much higher than that. Do you have an explanation?
For that, I'm not sure. I think we may have over-diuresed him.
Okay.
To be frank, initially when he presented, he had a JVP of 20 jugular venous pressure, so we were pretty aggressive on that.
That's excusable, obviously.
Question, please. I would like to ask a question, please.
Yes.
One point, usually with the AV fistulae, we have a dilated left side. With this, we usually have a dilated left side. So in this case, I see that he has the dilated right side, which is not the usual with these cases, with this level of shunt. Do you have this explanation for this?
So we think that what happened was that you have a myocardium that's already not very competent because of the prior disease, the RCA. And once the afterload that he already had because of the COPD and emphysema was overcome by an additional volume load that he was just not able to handle, that's when the issue arose.
Okay. Because usually with this kind of thing, we have a left side dilatation. Excuse me?
No, that is correct. Yeah.
Okay, I think we can take one more question, one more quick question. Yes, Professor Torre, please, go ahead.
Thank you for this excellent case presentation. My comment about this has to be emphysema, severe pulmonary hypertension. What is the role of medical therapy, soluble guanyl cyclase stimulator for the medical management of such a patient? And I want also to comment about the triple antithrombotic therapy. You decided before presentation after PCI to give this patient triple therapy because this patient is high thrombotic risk and low bleeding risk. The rule of versugoate of heart failure in such patients because the patient has
you cut off a little bit at the end, but I think I caught like the first question and its second question, so I'm going to answer it in 2 parts. Can you hear me?
Yeah.
Okay, perfect. So the question about the pulmonary hypertension medications, I think it's a fantastic question. In patients that he would have been a combination between group 2, given the severity of his coronary artery disease. This was someone that also had paroxysmal AFib and had tendencies to have elevated left atrial pressures. Consideration for pH therapy in this group, it can be a little bit tricky because you can overload the left atrium pulmonary venules and cause pulmonary vasodilation and worsening of pulmonary congestion, as you know. So it has to be like a PVR to SVR ratio of more than 33% for us to consider that the precapillary component is actually overriding the process. In his case, it didn't meet that criteria. It seemed like the pH was more related to the second component. In patients with disease and emphysema, parenchymal disease, he was on chronic O2, and he had emphysematous changes in the CAT scan. We were just concerned of causing shunting to abnormal lung parenchyma. So that's why we didn't do that. The decision about the triple anticoagulation, like triple therapy, he was on aspirin, and NOAC, I believe, and Plavix. It came because it was decision making with the patient of risk and benefits.
Okay, Thank you very much. I think we have to move on